estás? ¿Cómo llegaste acá a Uruguay? ¿Qué te ha parecido el encuentro con nosotros?
Bueno, me pareció que no pudo ser mejor. Es mi primera vez en Montevideo, así de visitar, y la verdad es que increíble, tienen todo, la historia, la cultura, la gente muy amable. Acabo de salir de visitar el Teatro Solís, es muy emocionante, y ni hablar del Congreso, pero de eso vamos a hablar de la ciencia ahora, enseguida.
Para mí realmente un placer recibirte acá. Como te dije, sos mi mentora, te he seguido desde hace muchos años y realmente desde los principios, desde que empecé a dedicarme a la cardio-oncología, vengo siguiendo tu trabajo. Así que es un sueño hecho realidad en realidad que estés por acá. Me alegro mucho que estés acá.
Muchísimas gracias. Igualmente.
So, here we are in the Uruguayan Congreso of Cardiology and with Dr. Anna Barac, one of the leading voices in cardio-oncology. Welcome. Thank you for joining us. You have just participated in the first ever cardio-oncology meeting held during a Uruguayan Congress of Cardiology. Based on your experience during this meeting, where do you see our main strengths and where do you think we still have opportunities to grow? And what advice would you share with our community to help us continue improving our cardio-oncology practice?
Well, we're switching to English because it's easier when we talk science, it's global. And I have to say, there are so many strengths. So I'll start with a few. First, you are able to put cardio-oncology within a global Uruguayan Cardiology Congress, which is huge because cardiology, while it's shared among the small community, it touches almost every single cardiologist. Every single cardiologist sooner or later is going to see a patient who is diagnosed with cancer, is being treated with some cancer, or has survived cancer. So understanding and sharing that culture is huge. And you gave it a very central place, and it was just incredible to see how many people attended, how many questions they answered. Yesterday, you started with the inaugural in the ballroom, and the key questions had 70% correct answers up front. Just phenomenal job. Second, huge strength. So I felt this morning we had a very unique opportunity that I cannot think of having it seen on that scale that you organized, a round table with, on one side, leading voices in hematology and oncology, and on the other side, cardiologists who work with them, many in groups, in different hospitals, representing public, private, and sharing experiences, identifying what's there. What I was surprised is that they were asking, oh, what should we do better? Well, you have the key concept is people around the table, the champions and interested in moving the field forward. A second thing that I was really, I shouldn't say surprised, but I feel I always learn through that. The questions and the challenges are global. The same questions you ask, how do we scale? How do we assure access? How do we assure that the patient who is not here in the center of Montevideo, being able to be seen in a private hospital maybe, how do we assure that there's access 100 miles from here where there might be a rural setting? All of those questions I have in Washington, D.C. and Northern Virginia area. And seeing, I think we all have the same, how do we create a protocol to risk stratify? Yesterday, we had a fabulous session on how do we create a risk model, but the biggest question is how do you implement? How do you actually reach that patient? How do you identify who are the patients at low risk, medium risk, and high risk, and how do you spend more time? So you have the strength of the culture, you have the community of engaged champions, and where I think you can, I wouldn't say improve, I would say lead the field, if you will, and show the example, is one suggestion among many that came this morning from our reunion when we said, let's create protocols together. Because right now, I've participated in many consensus documents, statements, guidelines, you name it, when professional societies come together and say, this is how we should do things. But we have to recognize that many things that relate to cardiovascular care in oncology patients are not based on randomized trials. So we sit together and we say, we think right now this is the best way. The truth is we haven't proven that because most of these patients, like the cases we discussed today, will never be part of trials. If you have heart failure and you have cancer treatment, there's just too unique of a situation to create a randomized trial around that. But that doesn't mean that we cannot do the best for the patient. And that will happen only when we create our own local protocols, follow these patients, and come back to that protocol 2 years later and say, you know what, this patient really, we've done well, or we could have done this differently. So what came from the conversation this morning is the creation of joint protocols, such as we sit together and we decide who are the patients. Are the patients who are receiving VEGF inhibitors? Are the patients who are older in age, who have comorbidities that need to be seen? Who are the patients that may not need to be seen? I think there's a lot of patients, the guidelines can say, well, get biomarkers in everybody, get imaging in everybody. That's part of the risk stratification. One can do the baseline. Based on baseline risk stratification, some patients don't need to be seen. And you all of a sudden create space and that dialogue that you already have for the patients at high risk. So I really see this sort of us maybe talking in 5 years and say, hey, based on that, we are going to change things. And I think that that's where the field is going to go globally. And I think you'll be able to share your local experiences.
Okay, thank you, Anna. Then I have another question for you. The increasingly widespread use of immune checkpoint inhibitors has been a game changer in oncology. From your perspective, what is the true magnitude of the impact on cardiovascular health and cardiovascular care?
That's a great question, and it was touched upon during the presentations as well. So immune checkpoint inhibitors, I feel that there is so much that we don't know. First, I think there is a huge opportunity for all of us because the side effects of immune checkpoint inhibitors are not only cardiovascular. And they're really, for the first time, we are organizing based on the therapy which is shared across different cancers. So that is also because before it was like, when we all start a clinic, you first need to go to the oncologists who primarily treat breast cancer. Then you go to the ones who treat lymphoma. Then you go to the ones who treat, and they often don't talk amongst each other because they deal with different treatments, with different regimens, with different patients. Patients with prostate cancer could not be more different than the patient with breast cancer. So, and we are all looking at them from the cardiovascular lens. The evolution of immune checkpoint inhibitors has really switched that because all of a sudden, these very different patients are all starting to have immune-related adverse events. So that not only, from our end, of course, we have to deal with urgent case of myocarditis, which I think has first surfaced extremely rare, but if it's there and severe, we all need to know about it. So we have a unique opportunity, everybody, from the emergency room doctor to interventional cardiologist, everybody has to have that bell somewhere in the electronic health record is going to say this patient could have myocarditis. If troponin is very positive and the patient is coming with immune checkpoint inhibitor, think of instituting this protocol. That's how I see it. That is a very rare complication, but one that people should recognize. The bigger question is, what is the long-term effect? We have no idea. And what I think is beautiful that right now, every place, and it was touched this morning, is starting to have the immunotoxicity groups. It's not only cardiologist and the oncologist, it's the dermatologist, it's the nephrologist, pulmonologist, hepatologist, neurologist, because it can touch any organ. And I think through those centers, we're going to start seeing, who are the patients on a long run? We are redefining, this is like a new natural history because we don't know what's going to happen in 20 years. So far, there hasn't been a patient. And the therapies are increasingly moving into the early stage disease. So survivorship is going to grow. I do think that from cardiovascular standpoint, it's going to be very important to look into the atherosclerosis. that right now all the retrospective studies, and this is not to scare or cause panic, if you say. I don't think that we are sitting on an iceberg of late effects. We would have already seen it. We have great survivorship now with diseases that people had very short life expectancy, melanoma being the prime example, and where the treatment has been now present in 10 years. And there hasn't been a signal towards huge, we would have seen if there was a huge toxicity. But I think there's a really unique opportunity of identifying what does activation of immune system mean for cardiovascular health. And increasingly, as often happens, we're seeing the twist. We are now having patients with heart failure transplant who develop melanoma, and I get a question, hey, can we give immune checkpoint inhibitor in a patient that we kept immunosuppressed until now? And those are the questions that we're going to have to redefine. So I think it's really, exciting questions coming at us, all improving overall outcomes. And I think what's most fun, we are going to be solving them together as a team, sort of subspecialties coming back together. So I think it's bright.
Okay, thank you. Well, through your research, you helped change the way we manage patients with mild ventricular dysfunction during anti-HER2 therapy. Looking ahead, what major changes do you foresee in cardio-oncology over the next few years?
Well, it was humbling to hear from you that you looked at our study designed. I often get questions, well, why didn't you use, this is about the Safe Heart study that we designed, a pragmatic study looking at the question whether it's safe to receive HER2-targeted therapy for a patient, for women at that time with breast cancer who have mildly reduced LV systolic function. We did not randomize. We didn't think that that would be ethical, and it showed that it wasn't, because the patient who has cancer, which is HER2 positive, the oncology benefit is enormous. So the survivorship is very important. And even in the case of metastatic breast cancer, the prolongation of life is significant. So therefore, our question was, is it safe? And we looked into primary outcome as the opportunity or the patients who were able to complete planned oncology treatment with a maximum defined as 1 year. And it was a positive trial. So what do I see? First, when we finished, I was very critical of that trial. It's only 30 patients. We did it at a time, and it was done at Georgetown, MedStar Washington Hospital Center, and Memorial Sloan Kettering joined us in the last part of the trial. And I felt, well, really, before we can change anything, we need another trial. What is happening, I think most places, like we do, have implemented it on agreement basis. We said, well, it suggests that it's safe. Sometimes we don't need to be doing official trials. I feel it would be helpful even to have a registry to know who are other centers who are following these patients. I think, and we coined the term afterwards, I think it was based in part on that study and others, permissive toxicity. When we know and we explain to the patient and the teams that we know that this patient has a higher risk, but we are accepting that risk. And I feel that's in essence what cardio-oncology does. It's in a way you cannot remove the risk, you can optimize, minimize, and it's a shared conversation with the patient. I think it really changes how the patient views, they feel informed. I still have to meet a patient who will say, no, I don't want to do it. And they all become engaged partners. And often the question is, how do I do it? How can I minimize my health? That's fine, I'll go for it. Tell me, can I exercise more? Can I eat healthier? All of these questions are so I feel it's gonna, the next step is more systematic implementation, and also trying to understand how can we grab those outcomes so that when we sit next together, somebody has already asked me, so what about sacubitril valsartan? What about SGLT2 inhibitors? Will that do better? Well, I think we would have to do either pragmatic or embedded trials with patients at high risk. And I think that population that we had was the patients with higher risk.
Okay, thank you. Well, as our final question, Dr. Barac, what inspired you to choose cardio-oncology as your field? And what would you say to younger physicians about this specialty to encourage them to embrace it with the same passion and dedication that you do?
Well, it is really, I certainly had no idea. I couldn't, in my wildest dreams, think that I'm going to be sitting in Montevideo, Uruguay, talking to you about the future. I'm originally from Croatia, from Split. And I went into this field because I liked questions about the mechanisms. Long time ago, I did molecular biology, and molecular signaling was my passion. And why one ventricle fails and the other one doesn't is something that inspired me along the way. And that's why I ended up in cardio-oncology. What I didn't know at this time, that I was really going to gain a wonderful new family, sort of global, that like to ask the same questions. So for the young people, I would say, follow your passion. Whatever that is, follow your passion. Questions will never go away. They're always going to be here with all the distractions from artificial intelligence, from the changes. I think people are always afraid of change. If you follow the questions, they will always be there. Second, surround yourself with people who inspire you, people who empower you, and where you can gain knowledge. So I think one beautiful thing that you created in this Congress is opportunity for young people, like this morning, to sit and see around and find their way of asking questions. Maybe there's a better way than doing cardio-oncology than you and I are doing, but we'll learn from the ones who are coming. So surround yourself, find mentors and sponsors, and never give up.
Okay, thank you. Well, before we close, thank you for being with us today, having leaders like you who not only advance science and patient care, but also inspire future generations through their vision, generosity, and commitment. It's truly invaluable for the growth of cardio-oncology worldwide. Thank you.
Many thanks to you, and it's an absolute pleasure and un honor. Gracias.